Well, a warm welcome to this talk, and regular viewers to the channel will be no stranger to Professor Robert Clancy from Sydney in Australia, consultant physician, professor of pathology, author of too many articles to enumerate, and of course an immunologist. Now, welcome, Robert. Thank you for coming back.
Great pleasure, John.
Thank you. So we've talked about the COVID vaccines before. I don't want to dwell on that, but I think we decided that one of the main problems with that was it wasn't really taking into account the host-parasite relationship and the way that this works in the respiratory compartment as well as the systemic compartment. Is that a fair summary, Robert?
Yeah, I think that's a good summary, John. What we decided was that when people looked at COVID, it was a very confusing, complicated issue. And much of the advice and discussion doesn't seem to take into account a modern understanding of exactly the immunology and the compartmentalisation of immunology. And so we decided to look at immunology from a layered historic context to try to decode it, if you like, to simplify it. And we started off by asking the question, what is the host-parasite relationship? And it's what infection is all about. For example, there's a lot in the news about meningococcal disease at the moment, and we know that many people listening here will have some of that organism in their nasopharynx, stuck in their throat, and yet they're not sick, and they're not going to get sick. And yet maybe 1 in 1,000 of those people can get a life-threatening infection, which is very serious, very rapid. And so we have this idea that the illness that you see is the outcome of the relationship between, on one hand, the pathogen, the bacteria or the virus, and on the other hand, the way in which the body handles that, which is the immune-mediated relationship. And so we're going to talk a lot about what a host-parasite relationship is, and particularly from the immunological viewpoint. Because if you get COVID, for example, the outcome of that disease is determined by the way in which that virus is handled. Is it contained? Does it get away from where it should be? And understanding those basic mechanisms is essential in making the decisions on how you approach management, be it vaccines, oral therapy, or isolating individuals because they may or may not be excreting the virus. So all of those things are tied up with this immunological concept of relationship.
And I guess this is true of any disease, Robert, that the symptoms that someone actually suffers from are a combination of the infection itself, the parasite, and the way that the body, the host, is reacting to this, is combating this, is suffering from the effects of this infection.
Yes, that's absolutely right, John. That if we look at something like, take COVID, because it's very topical, most of the problems that you get from COVID is not due to the virus itself, but it's the virus being in the wrong place and having an exaggerated, inappropriate body's response, causing, if you like, the viral pneumonia. But what we found was, that's how we thought about it right at the beginning. And then we found that the virus itself has a level of intrinsic toxicity. It has what's known as the spike protein. And the spike protein, I think, was a big surprise because that's the protein that we incorporate in basically all the existing vaccines. The spike protein itself can have a lot of damaging effect. And so, as with most host-parasite relationships, the outcome, the symptoms, the signs, the degree of illness is the combination of the way in which the body is responding and any intrinsic toxicity that pathogen, virus, bacteria may have.
That makes perfect sense, Robert. Thank you. Now, we want to go back and look at the historical development of this because we decided that immunity is such a complicated subject. Just to go sort of straight into the cutting edge of it wouldn't make too much sense. And we have to understand the way that the thinking is developed. And this isn't purely for historical interest, although it is historically interesting. But it's really to facilitate a deeper understanding of the nature of the subject and how the subject has been so misunderstood by many people who are even professionals in the field over the past couple of years. So going back to, let's go back to the 19th century, pre-1880. We had this idea that disease was caused by miasma and imbalance of the humours, which are lovely ideas. So we still say to each other, "Are you in good humour today?" or "You're full of bile," or something like that, which goes back to these ideas.
Black bile.
Yeah, the melancholia,
absolutely.
The black bile. I'm often melancholic. It goes back to these. So the
That's
first
right.
idea was miasma. What was the thinking what was miasma?
You know, it's very interesting. For 2,000 years, the idea of illness was some outside factor, some toxic miasma, would change a balance between four humours. And this, of course, was consistent with the way the Greeks saw the world, the universe. Everything was four: the earth, the fire, water. And when it came to humans, it was the black bile, the white bile, blood and air. And all of a sudden, the whole of medicine was identified in a disturbance of balance, which is quite interesting, because as we move on to immunology, you'll see we still talk about a lot of the balance and outcomes. Now, the great change that came was when Louis Pasteur in Paris identified bacteria. And what this did is, and it was probably the biggest change ever in medicine, it gave specificity to medicine. Because prior to Pasteur identifying particular bacteria with particular diseases, everything was non-specific, this non-specific change in balance. And so all of a sudden we had a particular type of pneumonia caused by bacteria number 1 or bacteria number 2 or bacteria number 3. And it was a simple jump from there for the people in Pasteur's laboratory and Robert Koch, who was the German competitor of Pasteur. There was no love lost between them in the Franco-Prussian War about the same time. They spent their lives, and their laboratory spent all their lives running around the world to find a new infection that they could find a new bacteria from. But at the same time, they found that every time they found a bacteria causing infection 1 or 2, they'd find in the blood some specific neutralizing factor, which ultimately became known as antibodies. And so antibodies have been around since the late 1800s as the body's response to a specific bacteria. So we're starting to get this idea then of host-parasite relationship in the era of specificity.
But this is sort of about 1880s we're talking here, when this work was really getting going, I'm guessing.
That's right. And things move so quickly, John. By 1880, Pasteur had set up his anthrax clinic, where he was treating people or animals mainly, who were getting anthrax. It was a huge problem in those days, and a very lethal problem. It was a big problem in New South Wales. We called it Cumberland disease, because until Pasteur sent his nephew out to Australia to fix up our rabbit problem, and he diagnosed the first anthrax in Australia. But this was the first vaccine. And he moved on to a vaccine for rabies, which of course is a viral illness. And
anthrax is bacterial, Robert, isn't it?
Yes, the anthrax was a bacteria, rabies was a virus. But he had no idea, of course, what a virus was. He saw them all as some sort of bacteria. And Robert Koch was doing the same. And I've just been writing something today on the bubonic plague that we had here in 1900. And that was a huge battle between a Koch acolyte and a Pasteur acolyte that rushed across to Asia to work out what was causing the Black Death that had appeared in its new waveform. So we had antibodies, and then very quickly people worked out that they could take the parts of the bacteria, or make the bacteria not causing illness, and inject it and stimulate the protective antibody without getting the disease. And so this was the beginning of immunology, the beginning of immunity. And so we went from the host-parasite relationship, which of course on one hand could be quite asymptomatic, or on the other hand, it could be a dramatic, overwhelming sepsis with death following very quickly. So you could convert someone into having, if you like, asymptomatic infection, getting the immunity without the disease. And that was the basis of the very early vaccines that developed. And at the same time, they could inject horses with the bacteria. They'd kill the bacteria first, and they would take the blood and make the antibodies from the serum. Well, didn't actually, they used the whole of serum to actually inject the serum into patients who were getting, say, pneumococcal pneumonia. And suddenly they were able to save patients by what they called passive immunisation. So we had active immunisation, where you made a vaccine by taking a product of a dead bacteria or a toxin produced by the bacteria, tetanus or diphtheria, or you would actually put the bacteria and grow it and grow it and grow it until it ran out of energy and could no longer cause disease, but it still had its antigens, the part of its body that would allow it to stimulate an antibody. And so you could take that inactivated, that fatigued bacteria and put it into people, and that would be a very effective, safe vaccine.
So interesting, isn't it? So the people before this recognised that there was a disease that kind of presented like that, and a disease that presented like this, and a disease that presented in another way. But then when they went and looked, they found the specific etiological organisms for that disease. A particular organism causing a particular disease, yeah. And then it's really so simple. Man on the moon.
Yep.
Yeah, yes, it's a complete revolution. But then it's so simple in essence. You just take the organism that's causing the disease, kill it, inject it in a dead form, and the body recognises that and actively makes its own immunity, which is the active immunity.
It changed medicine. Changed life.
Yeah,
it was
that's what the Chinese Sinovac vaccine was, wasn't it? It was just an attenuated virus.
It's an inactivated virus, and in fact, it makes a lot of sense. I mean, the flu vaccine that we've been using for 40, 50 years was just an inactivated flu virus, and then to make it less toxic, they broke it up and just pulled out the bits that were specifically stimulating a protective antibody. And so vaccinology has been a fairly crude science when you think about it. It's about making the bacteria or the virus unable to cause disease, but still able to stimulate protection.
And you brew these things up. It's almost analogous to making beer or something, isn't it? It's that kind of...
Well, that's how Pasteur made his name and his fortune. He found that when the beer went off... or when the wine went off, which was more important in France, it was due to fermentation by the wrong bacteria. And so, and of course, he found that tuberculosis from milk was the same, and he developed pasteurization from Louis Pasteur by boiling the milk, killing the bacteria, and making the milk safe to drink.
So really, I think we could call this... please.
No, I was just going to say that everyone hopped onto the antibody bandwagon. This was, and I think this is a very good way to sort of get to understand immunology, because this is really what immunology is all about. But a couple of things occurred within literally 4 or 5 years. The first was that the antibodies, sometimes they would inject all sorts of crude antigens into a dog or something like that, and in trying to protect it against putting in a live bacteria or a virus, although they didn't know what a virus was in those days. And they found that instead of getting protection, sometimes they got incredible inflammatory response. This is a very important concept, because this was the introduction of the idea of hypersensitivity, which basically says that sometimes antibodies can be protective, but sometimes if they're inappropriate or they're mixing up with the wrong sort of collateral agents, they can cause damage. And this was called hypersensitivity. And it introduced us to a very, very important component of immunology. And that is that the antibodies really can't do everything on their own. And if you think about it, there are at least 5,000 or 10,000 different patterns on bacteria and viruses in the world. And we just don't have enough cells to make hundreds and thousands of cells capable of marshalling an army of specificity to kill those bacteria or viruses. So the body's very clever. It adopted what had been around since the earthworm and very primitive organisms called the innate immune system. And this is a system of protection that predates both our knowledge and also humans, going way back to the invertebrate kingdom. It predates that to coming up with a system that could protect against infection without having antibodies or specificity. Now, those processes are what we now know as the innate or non-specific immunity. And they look like foot soldiers. We can think of the antibody as a general of an army. And what he does, he says, okay, army, I want you to attack. And so that army will attack that city or this city, whatever city that the specificity in the general decides needs to be attacked. And if you get that process of connection wrong, those soldiers just fire their guns anywhere. It's like a hand grenade. And it'll go off and it'll kill anything that's around. And if you don't target that innate system very accurately, that hand grenade will destroy part of your body. And, you know, I can remember as a student, John, all this stuff was not clear. And I remember going up to the professor and saying, look, how on earth can we have protection, prophylaxis, and damage, hypersensitivity or anaphylaxis? How can we have both of these being mediated by sometimes the same antibody? And of course, the answer is that it all depends on how connected and how controlled the specific antibody, and later we'll talk about T cells, but now we're talking just about antibody, can connect with this foot soldiers running around in the bloodstream. And if you don't get it right and you get an overactivity, then you actually get inflammation and damage. Inflammation is just a response to injury. It can be protective or it can be damaging depending how well it's controlled. But it's the non-specificity of this cells and humoral factors. And initially it was thought that the factors were in the serum or the non-cell part of blood, and the term was given eventually as complement because it complemented the antibodies. So you had antibodies and complement, which turned out to be a very complicated series of enzymes and proteins. But they would have amplification systems built in to achieve the outcome in a time frame. And time frame becomes incredibly important because if you've got bacteria and virus dividing, you have to control that infection quickly. And so that's why the activation of this innate system and its control is so important. You set that hand grenade off just to kill the bacteria. But I think the idea of hypersensitivity is very important because when we come to COVID, we'll find that the pneumonia that you get as the virus gets into the gas exchange part of the lung is due to a hypersensitivity, due to the IgG antibody, the antibody recruiting inappropriately and excessive these innate immune mechanisms.
It's incredible. So basically it's a race. The organism is frantically reproducing. If the organism reproduces enough, it will kill us. So we have to activate our responses quickly. And if we have to activate our responses quickly, that means these responses have to be potent. And if we take that non-specific mechanism like complement, for example, it can make these perforator proteins, can't it, that can actually lead to cell death, which is good in the right circumstances. But if you have too much of that, if it's killing cells inappropriately, we're going to get an inflammatory response. So it must be precisely moderated just to attack the attacking organism and not attack anything else and not cause other inflammatory mechanisms, because inflammation can be good, but inflammation can also be deadly, as you mentioned, if it's in the...
Exactly. I think that's a really important point, that inflammation is just a term we use for response. We tend to get it wrong by thinking it's damaging. You know, you've got a hot red toe in gout. That's an inflamed toe. In fact, if it does its job properly, then it does it without getting hot and red and inflamed, and involves these non-specific cells and humoral or soluble factors in the serum of blood or the plasma of blood.
So really what we're learning from this is that we have these two things. We have the innate response and the specific response. The specific response is a specific organism, a bacteria or a virus, generating a specific, like, reciprocal antibody that's specific only against that organism. But we can also get the activation of this non-specific response, like the complement. And later on we would learn that the innate response would probably include the natural killer cells that can kill a wide variety of cells. These are acting in tandem, and they need to act quickly so that
Yes.
the attack can be dealt with.
That's quite true. Now,
Yeah.
the other
Before we
interesting
pass
thing,
on,
John,
Robert,
that occurred.
Yeah.
I'm
Go
just
ahead,
going
please.
to amplify that what was found with this hypersensitivity reaction was that it was time dependent. That if you, for example, did a skin test in somebody, you could get inflammatory or a positive swelling and redness very quickly within a minute, or it could occur after several hours, or sometimes after several days. And so very early historically, it was recognised that there were the three forms of hypersensitivity or inflammation causing damage. And we'll jump forward and cheat a little bit because it was found that the first type, the very quick one that occurred within minutes, is caused by a particular antibody that wasn't really discovered until about the 1960s by a Japanese couple. And this is the Ige antibody, because most of you will know about the IgG antibody, because that's the one that we're going to talk about causing COVID. But the Ige antibody is the one that causes allergies, hay fever, asthma, eczema. And this antibody binds to cells which release factors like histamine. You're all familiar with histamine, antihistamines. And that was the immediate type of inflammatory response. And that's why when you go to the allergist, he does skin tests, bit of house dust mite, bit of grass, weed, to see which type of specifically what you're allergic to, because he may want to then desensitize you by injections and turn off that process. The second one took hours, and that was caused by IgG antibody binding to complement, which we just talked about, causing a swelling and redness. The third one was tricky because they couldn't find anything in the blood serum or the blood plasma, that's the non-cell part of blood, that could mediate this by transferring to other people. And what they found was that it must be a cell rather than an antibody. And so the idea that there were more complicated processes involved in immunology involving cells was seeded very early. And this, of course, was the work done by Robert Koch in Berlin and became a key part of our understanding of tuberculosis. And the Mantu test, which many of you would have had, because that's the one you come back to the doctor 2 days later to see if you've got a lump. That's the T cell mediated, or the delay, what was called delayed type hypersensitivity. So we have protection, we have hypersensitivity and damage, we have immediate, intermediate and delayed caused by antibodies or cells.
It's incredible, yeah. And the cells turned out to be T cells, which we'll come across later, which is interesting.
We better not cheat too much.
No, we won't cheat.
Some minutes ago, though, I said there were two things that were found. The first was this idea of damage as well as protection. The second was, and it came straight after the third of the great thinkers in this time period, a man called Paul Ehrlich, who was also German, as was Robert Koch. And Paul Ehrlich said, this wonderful observation by Pasteur only occurs against not self, something outside of the body. You could never have a reaction against yourself. the very next year, another German, Landsteiner, who's responsible for sorting out blood groups, he found that in a poor little child with congenital syphilis, an autoantibody was there, an antibody that was killing his own red cells. And so within 12 months of Ehrlich saying a term known as horror autotoxicus, you can't possibly have an auto-reacting toxin antibody, Landsteiner had shown, yes, you can. And that, of course, was the beginning of autoimmunity, which is a very large part of what I do from a clinical viewpoint.
So this is 1920s, Robert. I'm guessing now.
No, this was earlier. This was before 1910, 1906, 1907. Yes, very early.
Right, okay, right. Yeah. So just to clarify, we've got extrinsic antigens, which are the viruses and bacteria.
Yes.
And we've got autoantigens, which are part of ourselves. Is that
exactly
basically, or is that too simple?
No, it's exactly.
And both of those act as antigens, which can stimulate the production of antibodies.
Exactly. And if we jump forward a little bit, we'll find that there's an organ up here behind the breastbone called the thymus. And the thymus has the job, before we're born, of sorting out whether your cells are autoreactive or whether they can be there to defend yourself against bacteria and viruses. And basically the thymus has this regulatory function of getting rid of the autoreactive cells and letting only the non-autoreactive cells get into your circulation and into postnatal life. Now, it's not quite as simple as that, as we'll find out, but that's more or less the broad idea.
Incredible, yeah. So it's possible to have autoantibodies that, for example, destroy the beta cells in the pancreatic islets of Langerhans. That's
exactly. Juvenile type 1 diabetes is an autoimmune disease where the beta cells that make insulin in the pancreas are destroyed by an autoantibody. We have many, probably the commonest one would be systemic lupus erythematosus, or lupus, which many people will have heard of, where you have autoantibodies against parts of the broken down cell nuclei, causing complexes which cause all types of problems. But I guess we'll get onto that a little later.
So again, we get the idea that antibodies can protect or cause damage.
Exactly. And when we think about it, within 20 years of us going from the idea of 4 humours and balance and miasma, in 25 years, we've gone to the basic tenets of immunology as we understand them today. We have antibody system coming from what we now know as B lymphocytes. We know that there's some cells, we don't know much about them. We know that these antibodies can be protective. We know that they can react in an allergic or hypersensitivity way and cause damage. We know that under the wrong circumstances, they can actually direct against yourself. So you actually have the pattern of immunological diseases starting to be fairly well understood in many ways within 20, 25 years of the whole idea of specificity being born.
Yes, all this we've talked about here is completely recognisable. For example, you'd recognise this reading a modern textbook, and we're talking about basically getting on for 120 years ago that these ideas have been around for.
I think the problem, John, has been that we immunologists tend to use mouse names. We talk about the complexities, and as we progress, we'll realise that when I started an interest in immunology, there was still this big black box, this whole concept of how the molecules and cells become interactive. And of course, that's of great interest to people like myself, but it takes away from the simplicity of understanding exactly what's happening. Mm-hmm. Now, I think by the time we got to 1920, World War I, wars have terrible outcomes and sometimes great discoveries. I just wanted to introduce the concept which you really talked about right at the beginning, and that is the compartments, because up to now, everyone was thinking of what was happening in the bloodstream, systemic. We call that the systemic immune response, occurring inside the body, operating very quickly because it has to cope over very short time frames. But there was an amazing man, also out of the Pasteur Institute, called Bezrekka. Now, Bezrekka was a very famous immunology at the time, and he realised that with some infections, for example, dysentery and typhoid fever, which were particularly involving the gut, he was finding some antibodies in the stools of patients before he saw them in the blood. And he said, well, that's interesting. Maybe what's going on in the gut is particularly relevant to an infection of the gut. Maybe there are different compartments. And to cut a very long and important story short, he actually immunised soldiers in World War I with killed dysentery bacteria and showed that you could protect against dysentery to some extent by immunising by the mouth to actually activate what he saw as some form of regional immune system. Didn't understand the details, but he understood that there was a separation. That becomes really critical when we look at COVID, because COVID is an infection of a mucosal compartment. It's an infection of the lining of the breathing tubes in the lung and the upper airways. It's only when it gets out of those breathing tubes that it causes a lot of mischief.
Fascinating character, Alexandria Beretska, I think it was. He was a medical officer. A medical officer in Verdun.
That's right.
In the First World War.
He was born in Odessa. What country is Odessa in? Is that? I know he's born in Odessa. Ukraine. He's Ukraine.
That's Ukraine. Yeah.
Well, there you are.
But he was working with the French military. Verdun, of course. People will know this. You'll know this. It was an appalling killing ground in the First World War, and the French army was stuck there for a year at least in the trenches. And he noticed men passing, getting really bad gastroenteritis with mucus and blood.
That's right.
And,
that's right.
I think this turned out to be Shigella, Robert, didn't it? Shigellosis.
Yes,
dysentery.
It was Shigella. That's right. Shigella dysentery, and he would take the Shigella, grow it up, inactivate it so it wasn't toxic, and feed it to the soldiers. He had a very illustrious career, and he actually ran the Pasteur Institute for a period of time. Quite an amazing man, not just in mucosal immunology, but just if you give me just 20 seconds, it brings me to.
Oh, please.
I had a very important person in my life died last week. It was John Bienenstock, and I know many people watching this, his family and friends I know are supporters of yours, John. John was the father of modern mucosal immunology in the sense that there's communicating networks between the different mucosal surfaces. He was also my mentor, my guide, and one of my very best friends. And sadly, at late 80s, he died suddenly in the street. But I just want to pay respect to him because John was the person who first showed that cells would migrate from one body surface to another. And we'll get on to how important that is in understanding protection of the airways and protection against COVID. So, John.
So he was very much working on developing the work of Alexandria Beretska.
He introduced me to Alexandra Bezrekka. In fact, he had a copy of his book, and Bezrekka was John Bienenstock's great hero.
Indeed. I really love that. It's such a simple idea that Alexandria Beretska had. He looked at the stools that these soldiers were passing. He found there was antibodies in there. He realised that these antibodies must have come from the gastrointestinal tract.
Because they weren't in the blood.
Therefore, he postulated this idea of gastrointestinal immunity. They weren't in the blood. Therefore, he gave attenuated or dead bacteria, stimulating the same antibodies, generating mucosal level protection against Shigella, and in doing so, saved unknown tens of thousands of lives.
That's right.
But by that sort
amazing man.
Simple sequential thinking doing that. And so rather than injecting vaccines as had been done before, he just simply gave them orally to work in a particular compartment.
Yeah, and I think that this is such an important principle. If we take influenza or COVID-19, these are primarily mucosal infections. And so if we inject the antigens, they won't have any impact on the behaviour of those organisms in the airways. And that's why the vaccines are very effective at preventing people dying or becoming extremely unwell once that bug gets into the alveolus, where the gases are exchanged, because that's where the IgG and systemic immunity can operate. But it won't impact on the division in the bronchus. And the bronchus, of course, is the conducting passages. And that's why the vaccine has very little impact on preventing spread of the infection. So you can be vaccinated and maybe just get a cough and a bit of a wheeze, but you're still going to be infective in a community. Maybe not quite as much, but certainly infective. Whereas it'll protect you from the virus going down and meeting a pro-inflammatory antibody like IgG, which could create so much damage.
And I suspect Alexandria Berezka and your friend John would have both realised this straight away.
Absolutely, absolutely. Unfortunately, they're part of a very small group.
Indeed. But I mean, we learn this from nature itself, Robert. I mean, colostrum that mother produces in the first day or two of breastfeeding.
Yeah, absolutely. And for animals,
the immunoglobulins that line the gastrointestinal tract of sorry, what you say?
Yeah.
Animals what?
No, a lot of animals really depend on the colostrum and milk from their mother, and humans do too.
And of course we can't recommend it highly enough for human babies either.
Absolutely. I mean, there are a lot of reasons why breastfeeding is absolutely critical, but and the breast is part of this common mucosal system, and there's transmission of ideas between these surfaces, and you have a singular. Aggregated lymphoid tissue in the gut is actually the main factory for the antibodies. And the antibody is a very different type of antibody. It doesn't fix complement in the same way that IgG does, so you don't get this pro-inflammatory effect, which, of course, you don't want at your mucosal surfaces. So there are great differences between these compartments.
And of course, you applied this in one of your inventions, which was basically the oral vaccine for recurrence of chronic obstructive pulmonary disease. Just sketch that out briefly for us, Robert, if you don't mind.
Well, I was very lucky. I worked with John Bienenstock for 5 years, and my first job was just killing the rabbits. He thought I was an Australian, and so he gave me the job of killing the rabbits because he thought all Australians hated rabbits. But I wasn't as bad as my Canadian colleague who I worked with would take them home and eat them. But what...
I'm sure he did it very humanely, Robert.
Oh, very humane. Very humane. I quite like rabbits. But what I did when I went back to Australia was I thought, well, look, does this work in humans? And so I set up model systems, and I particularly in chronic bronchitis in people who were smokers. And we were able to show that the system worked very effectively in humans, and but it wasn't 100%. And that we could make that system of protection work far better if we actually took the main bacteria from the airways, did what Pasteur did and killed those bacteria, fed them in large amounts, protected them from destruction by acid in the stomach, and we got this surge of protective cells and antibodies that would protect the airways in animals and in humans against infections. And we were able to, by doing this, people with emphysema and chronic airways disease who dread the thought of getting a virus infection because it so quickly goes to their chest and they get serious problems because they've got compromised lung function, we were able to reduce admission to hospital by 50% in those patients with chronic production of sputum and cough. So simply by making a normal natural process work in an optimal way. So the understanding of the basic immunology really does have some practical outcomes. Don't ask me if you've ever worked in pharmacy.
We can talk about that, but if you've ever worked in healthcare, you'll realise the impact of what Robert has just said. If we could reduce admissions of COPD or exacerbation of chronic COPD by 50%, then we could probably take most of our afternoons off, because it's a huge amount of work for the health services that these people come in, and a huge amount of suffering. Why the heck isn't this being done, Robert?
Sorry, what's that? Can you ask the question again?
Why isn't this being done? Why isn't your vaccine invention being used?
Look, it's a long story, John. I'm not a commercial person. I'm not a very good commercial person, and it's over many years we've actually developed this to a fine point. But maybe it'll happen in the not too distant future. I'll talk to you.
I think we'll leave it on that cryptic note. We'll leave it on that cryptic note, which I'm very much looking forward to. But when and if this is operationalised, if we could reduce admissions of these patients by 50%, that would be huge. Because our surgical wards every winter are full of COPDs.
Yeah, it's all in the literature.
Absolutely.
We've done about 8 trials on it. Yeah.
Yeah, we're looking forward to something on that. Just out of interest, Robert, did you use a sort of a combination of bacteria and viruses from mucosal secretions and grew those up? Was it?
That's a very, very good question. In Europe, anyone listening here in Europe will know of a number of products, and they're very interesting products. There are lots of different bacteria in small amounts, and this comes out of, again, just after World War One, when influenza. The Spanish flu, the flu that killed 50 to 100 million people, when that appeared, a lot of people were young people who were dying. And they would get flu, but they would die from a bacterial infection of the lungs, mainly staphylococcal pneumonia. And a number of people in both Britain and Australia and various parts of America started putting together, because the idea was that bacteria, because viruses weren't known at this stage, bacteria caused all these infections. They didn't know what bacteria, so they just went to people's airways and grew up every bacteria that they could find, put them together and injected them. Now, the amazing thing is that 50% of the people who were treated this way, or there was a 50% protection against dying from staphylococcal pneumonia. Now, those figures were found in both England and Australia. They're a bit hard to validate now, because no one's going to use that sort of treatment. But it was picked up in Europe and became very common as an oral form of multiple bacteria. And what we do know is that those bacteria, they don't stimulate the specific immunity that we get the way we do it, but they stimulate all the T cells so that everything's working in upregulated fashion. And you get a level of protection against everything. Not a lot, but some. And so so the Bucoline is one. There's Bronchovaxum. I mean, there's a whole range of these products. There's at least 4 or 5 of them in different countries in Europe.
So you just get an upregulation of the whole T lymphocyte system. That's
exactly. It basically primes them so that they can work just that little bit better. And there's a lot of data. We did a lot of work on this, but it wasn't nearly as effective as using the high dose, protected doses of particular isolates that we were using.
Right. Okay. So you've got the general up-regulating of the T cell system, and you've got your more specific stimulants.
Yeah.
Got it.
It's a bit like walking into a classroom and you've got all the boys misbehaving and you kick them all in the pants and they all respond, or you pick out one and say you're particularly bright and you go to the blackboard. It's the concept of specificity and non-specificity. We're really going back to the dark ages of the 4 humours, in a sense.
No, but if it works, I mean, it's almost like the you're stimulating the innate or the specific, isn't it? Again, it's
yeah. Well, it is.
Going
it
back
is
to that
basically
original idea.
It is. It's innate immunity, and the whole area of innate immunity has undergone massive change. We gave it a bad press initially by not really saying that it has a level of specificity. But what we do now is that it's the innate system that actually gets the specific part, the T cells and the B cells, working in a directed and powerful way. And maybe we can talk about that another time. We're starting to get into complexities of cells and molecules.
Yeah. But I think it's a valid point, because we tend to think, well, there's an innate immunity and there's a specific immunity. But in actual fact, they interact. It's always more complicated than
absolutely,
I think, isn't it?
Absolutely. But I think by trying to do this in a layered, historic way, we can see how each part has its role, has its part, how it can go wrong, and how it can be protective and useful.
Yeah. Now, I'm almost ready to go on to the cellular era, Robert. But just before we do that, I've got serum sickness down.
Okay.
As a note from this earlier period. Now, I've never understood serum sickness in the last 40 years. Please enlighten me. What the heck is
we've already
serum
talked
sickness?
We've already talked about it. We talked about hypersensitivity. And I remember I said that there were 3 types differentiated by time. One, if you inject the antigen into your skin and it comes up within a minute, it's immediate. If you do it and it comes up in a couple of hours,
IgE,
it's IgG and it's intermediate. If it's a couple of days,
IgG.
It's going to be a T cell, which we'll talk about later. Now, that IgG antibody and that several hours delayed reaction, that is serum sickness. Because what happens and we went back one step further, we talked about passive immunisation. You would, for example, take a pneumococcal, that's the bacteria that causes serious pneumonia in young people. You would kill it, inject it into a horse, and make lots of pneumococcal antibody. They'd take the horse serum and inject that intravenously into a patient with pneumonia. And most of them did moderately well. But, of course, you're putting all this foreign protein into the serum, and they're making an IgG antibody against this. And so about 20 or 30% of those people will fix complement and cause all sorts of complexes to be formed. And these complexes, with the antibody, the IgG antibody, the antigen, which is part of the horse serum, maybe IgG protein, and the 3 of them form a complex that deposits in very small blood vessels, in the kidneys, in the joints, in the skin, in the gut, probably in the brain and other parts as well, but they're the main organ targets. And once it fixes there, it recruits an inflammatory damaging response with white cells coming in called neutrophils as a result of breakup of the complement, because it makes a factor which drags those cells in. And so you get cells and edema and inflammation. And so you get renal disease, inflammation, glomerulonephritis. It's itis, just means inflammation. You get arthritis in the joints, where you get those complexes deposited. You get gut aches and pains. You get skin. You get urticaria or skin lesions. Wherever you get the complexes deposited, you get symptoms. And so this is called vasculitis, because it's inflammation of the very small blood vessels, and it's caused by the antibody, antigen, complement complexes formed by the IgG antibody in you and me getting the horse serum against proteins in the horse serum. That's serum sickness.
That makes sense. Yeah. These immune complexes, the antibody and the antigen, are like basically all over and can cause, as you say, a wide variety of
you can get very sick
conditions. And of course, maybe the reason I've never understood it is we'd yes, you'd be. It's because we don't do that I've never seen it. Maybe that's why I've never.
But we see it in different forms now. We see it with certain drugs and medications. They can form complexes and create an antigen in the blood, and you can get the same type of situation. Or you can get autoantigens involved, and you get the same type of serum sickness. That's what happens in systemic lupus erythematosus, SLE. You get antibody against soluble proteins from breakdown of nuclei of cells, forming a complex. The complement gets attached to it, gets deposited, and you talk to someone with lupus, they'll say, I get a rash in my face, I get itchy, I get aches and pains in the small joints of my hand. The doctor tells me that I've got protein in my urine, or a host of other problems depending on where the immune complex is deposited. So that is immune complex disease, right, like serum sickness, but it's part of autoimmunity because the antigen is not an external antigen like a drug or serum from horses. It's an antigen from yourself. And so you're bringing together all these simple components.
That makes sense now. So with the original serum sickness, it was like a horse antigen. Our antibodies forming those immune complexes, which would get lodged in different tissues, causing things like glomerular nephritis.
Yes.
Whereas now it's an autoantibody and an autoantigen generating an autoantibody. Those two clump together, forming an immune complex that lodges in different tissues, and that causes localized inflammatory responses. But it can be anything.
Exactly. And the treatment pretty much is the same. Initially, it was corticosteroids that were developed in the late 1940s, and they're very powerful anti-inflammatory. And all they do is dull down this host inflammatory response until the antigen gets cleared or it goes away. With autoantigens, of course, it doesn't always do that, and you have to bring in more powerful ways of suppressing that immune response.
Yeah, that's really helpful because I can now see serum sickness, which was a problem in the past, viewed in context of current pathophysiological processes. Thanks for that.
It was the details of sorting out serum sickness that led into understanding a lot of modern... And all the work, a huge amount of work was done on these problems in the 1930s and 40s and 50s. Complement, there are books that thick, written about complement. There's a chap called Campbell. I remember they had this terrible book by, I think his name was Campbell, stuck when I was doing a PhD, stuck on my desk. And I just couldn't bring myself to read it.
I've done that quite a few times when I've been studying for exams. You have a particular book and you leave it on the desk and you hope that by looking at the cover
that it will
somehow help. Yeah. Diffusional. Now, I think the next era we want to discuss, Robert, is the cellular era. And I think this started perhaps as early as 1940, but wasn't really recognised until about 1970. Does that sound about the right time frame for the cellular era?
I think right from the earliest days, it was recognised that you couldn't explain all the immune protection or all the immune damage, hypersensitivity, just in terms of different classes of antibody. And the idea of cells was around for a long time. It got developed very much through the 20s, 30s and 40s by people doing experimental work on animals for autoimmune disease and found, for example, a disease some of you would know about called Hashimoto's disease, which occurs in 2 to 4% of women. It's a thyroid autoimmune disease. Many people in my family have got it, so it's not at all uncommon. And they could create this disease in rabbits and transfer from a rabbit with the disease to another healthy rabbit by taking purified lymphocytes from the blood. And so the idea of lymphocytes mediating an immune response was around, but it wasn't till Jacques Miller, working in London, French-born, Australian brought up, Jacques found that if he took baby mice and took out the thymus gland, which I talked about very briefly before, if he took that out, those mice would not develop a whole range of different types of immune responses. And he was able to characterize the cells from the thymus gland, which were given the very imaginative name of T cells because they came from the thymus gland, just as B cells, I guess, come from bone marrow. Immunologists are not very imaginative, really. And that, of course...
I think B cells originally were discovered in birds, Robert.
They were.
I think it actually goes back to B.
They were. The bursa of Fabricius. That's...
Yeah, and it's just handy that that bone and bird begin with the same letter.
Support my simple story. But...
Sorry, apologies.
I was a medical student at the time, and it was such exciting to suddenly find that some of these poor, unfortunate children with congenital immune deficiencies didn't have a thymus gland, and suddenly, through work done by Robert Good in New York, we start understanding these immune deficiencies, and then we had all sorts of changes, and the big black box started shrinking. Jacques came back and worked at the Hall Institute in Melbourne, and he, with Graham Mitchell, decided that showed that some of these T cells could help the B cell make antibody. And so we had helper B cells. And then another American showed that some T cells could turn off the B cell making antibody. And so all of a sudden, the huge change that came was that we went from an antibody era to a cellular era. Now, to be fair to Macfarlane Burnet was the person who introduced the idea of the cellular era by simply showing that antibodies, what he said was that B cells have antibodies on their surface as a receptor. And this idea of cells with specific receptors came from out of the antibody story when Burnet developed his great idea of selection as a way of identifying why we had antibodies against outside antigens but not against yourself. And what Burnet said was that those self-reacting B cells would be destroyed before birth, which in a sense they are, the ones that weren't would be there to react against all those huge numbers of antigens outside the body. And this led to the whole concept and idea of regulation, when you had T cells that could control, up and down regulate the B cell. And in fact, Burnet he had to come up with an idea for autoimmunity. And that's when he said, we have somatic mutations going on in these cells, and finally they make an antibody against yourself. And he called these the forbidden clones. And that was my introduction to autoimmunity. I was a first-year medical student, and someone came back from a talk that Sir Mac gave down in Melbourne. I grew up in Sydney. And they said, there's this man called Burnet, and he's talking about the forbidden clone. And so I just thought, this is what I want to do. I want to be a forbidden clone doctor, which is what happened. But it all began with Burnet, and then Jacques Miller came back and worked with Burnet and Gus Nossel at the Hall Institute and came up with the idea of regulation through the T cell. And of course, that's just gone on now to the complexities of, amazing complexities of cytokines, and we could talk about it perhaps next time.
So these forbidden clones are basically B cells that would contain autoantibodies that are filtered out by the thymus gland before
exactly.
birth.
That's how Burnet saw it, because remember, this was about 4 or 5 years before Jacques Miller had actually discovered the T cells were from the thymus gland. So everything was very antibody orientated. And what Burnet did is by saying, I think that there's a selection process going on at a cell level. And the way it's done is the receptor is actually the antibody sitting on that cell. So you've got every B cell has specificity.
Yeah.
And this antigen will only react with that. And then it'll divide, and you've got lots and lots of them, and you get lots of antibodies in response. And that was the beginning of the cellular era, which was consolidated when Jacques Miller came up with the T cells. So we had B cells and T cells. It took a long while to come up with the T cell receptor.
And
So,
yeah, sorry, the B cells with this specific clone for this specific antibody.
Exactly.
When that's selected by the antigen, these these B cells with a specific antibody will divide and become plasma cells.
Exactly. And you'd have lots of them.
And it's the plasma cells that then, and millions of them, billions of them, and these plasma cells, are these the ones that actually secrete the antibodies into the plasma to give humoral immunity?
That's right. You've got each plasma cell produces each plasma cell produces one antibody, one type of antibody, and they divide. And
but they're excreted into the humours of the body. They're
the factories.
They're not bound to the membrane.
No. They're factories. They're making the antibody and secreting it. And if it goes wrong, you get a disease called myeloma.
Just before we do that, I've never quite got that before. So, in the B cell, the antibody is attached to the surface membrane of the B cell. But when they differentiate into plasma cells, the plasma cells actually secrete the antibodies into the humoral
That's
immunity.
Right. The B cell actually makes the first antibody that's plastered on the cell membrane. It makes it. But when it transmits into a factory, it's called a plasma cell. And its only purpose in life is to make that particular antibody. If it goes wrong and it becomes a cancerous plasma cell, you have a disease called multiple myeloma, and you get all sorts of problems by having huge amounts of IgG or IgA or IgE or all the different classes of antibody type myeloma cells. Nasty disease.
So myeloma is basically a cancer of B cells, Robert. Is that the best way to look at it?
Yeah, it's a cancer of plasma cells. Most of the cancers of B cells are more called lymphomas. So lymphomas they can be T cells, but most of them are B cell lymphomas. And there's a huge variety, depending on what stage of the B cell development becomes malignant.
Mm-hmm. Right, okay. It's quite a subtle distinction, but I see that. So basically, we know these small lymphocytes. We have now we have the T helpers, the T suppressors, and the T cytotoxic cells.
That's right. We didn't talk about the T cytotoxic.
And the helpers are No, but the T helpers are stimulating the B cells to make the antibodies.
That's right.
And of course, it's the T helper cells that are damaged by the human immunodeficiency virus, isn't it?
Exactly. The CD4. They were all given little names, and this is the CD4 cell. They have a receptor which the
CD4s.
Which the HIV, the AIDS virus, can bind to and destroys, and you can measure how sick the person is or likely to become by just measuring the number of T cells in the blood.
And then when there's been enough immune response, as it were, the T suppressor cells will inhibit the proliferation of the B cells and the plasma cells.
Yes, this was a fairly primitive concept back in the 70s and 80s. It was thought that the B cells and also the T cells that were doing things were regulated by different subsets of helper or suppressive T cells. The idea of regulation was a very good one. And lots of loops of ancillary regulatory mechanisms became involved. It was never simple, but the concept is one of regulation. And then I'm not sure, John, if you want to keep going now, or do you want to? Because we now move on to the era of.
No, I think we'll probably leave that hanging in the air now. We're sort of into the era of cellular immunity, aren't we?
Yeah.
Yeah, I just got one more question thing I don't quite understand is that these T helper and suppressor cells, will they help and suppress the T cytotoxic cells as well as the B cells?
Yes, they will. Yes, they will. And when we progress and talk about how this occurs, and there's a raft of Nobel Prizes get given at every junction as we better understand the immune system. We'll talk about the antigen processing cells or dendritic cells, which are really from the innate system coming together with the adaptive or specific immune system. And that's a story in itself, but very important because it relates to regulation, autoimmunity, host-parasite relationship. So we can actually finish by coming way back to that host-parasite relationship. We've suddenly gone from the very beginning of a crude, not so crude, but a very simple system where you've got the B cell or the antibody, if you like, interacting with part of a virus or a bacteria, and the regulation was simply getting rid of the bacteria, getting rid of the virus, so there's no more stimulus. We've moved on through systems where the innate immunity was critical to getting an outcome for protection, or if it goes wrong and it's inappropriate and excessive, the foot soldiers go off like a hand grenade and cause tissue destruction. And then we've moved on to the fact that there's another arm to the immune response called cells, first thought of in the old hypersensitivity testing, couldn't explain it all with antibody. Here are the cells. And then Burnett saying, well, let's give some authority, let's give some ownership to cellular immunity by putting receptors on their surface. Let's make antibody. We know about antibodies, and these are B cells. And then comes Jacques Miller to say, well, I found out what the other cells are. I'm calling them T cells, or thymus-derived cells. And so we have this collaborative system, and regulation started taking off in earnest, and the black box started shrinking.
Incredible. That's 100 years of immunity, Robert. I'm quite I'm quite exhausted after that, to tell you the truth. Well, it's so interesting, but so much to keep up with. How do you think I feel? Now you're going to have to come. You've done it before.
Oh, it's late at night for us.
Now, yeah, that's true. That's true. For the next enthralling episode, you're going to have to come back to learn about monocytes, macrophages, dendritic cells, the way that these are controlling.
But we'll make it very simple. We'll make it very simple.
And we'll also be moving on. Oh, always. We always make it simple. We simplify without being simplistic. Then we have to move on to the immunogenetic era, and the implications of that for things like allergy, immune deficiency, immunosuppression, and of course, we'll get around to cancer as well. So the molecular era and the immunogenetic era to come, and then we'll finish with the cutting edge. But for now, Robert, we've covered 100 years of immunity. I've certainly learned so much. And I really think it's important to, well, firstly, we all stand on the shoulders of giants, don't we?
We do. And we've talked about a lot of giants, a lot of Nobel Prize winners.
Yeah.
I mean,
yeah, and it's right to pay homage to these people, but as well with this complicated field, it is the best way to understand it.
Well,
it really
I think
is.
so, because it looks. So, we talk about it, and I guess we try to make it understandable, because the principles are understandable and simple. But there is a giant at every flexure point. And at every flexure point, there's at least one Nobel Prize. The conceptual ideas have just been so mind-blowing. And, it's very hard not to get excited about immunology. I'm a little biased.
No, I agree. And we're just sort of almost niggling at the surface of the complexity of living organisms and human physiology, which is just... Never.
What I find very interesting, John, is that I've been lucky enough to live and work through 50 years of change. And when I first, as a student, got involved and interested in immunology, it was a huge black box. We were just coming out of the antibody era. Jacques Miller, I think it was 63, I was doing a year of science research in molecular genetics. And this idea came, someone's taking thymuses out of baby mice. When I got over the fact, I thought it was rather cruel, that these mice couldn't make cellular immunity. And the next year, I was doing a paediatric term, and Robert Good, the other great thymus inventor, if you like, was visiting Sydney, and we had a patient with what's called de George syndrome, which is congenital absence of the thymus. So within 1 year of Jacques describing this amazing change in biology, here I was seeing a patient that didn't have a thymus gland. Now these days, of course, we can save a lot of these children by genetic transfer and transfer of cells and whole range of very clever technologies. But of course, in those days, it was just not possible.
Always good, though, to link the theory to the practice. And
well, that's what I like, yeah.
This is also how the whole learning process has developed.
Absolutely. I sometimes...
Robert, thank you. It's your bed.
I was just going to say, I think my great disappointment... I
was going to say it's your bedtime.
No, I don't go to bed. What's... I do. But what I find so disappointing is that more or less at the end of my clinical and research career, all the things I wanted to have when I started are suddenly starting to appear. You know, we can make huge inroads now into cancer. We understand autoimmunity. We're doing really... a very good friend of ours has just had T cells sent off to America to reprime a woman with lymphoma, and the lymphomas disappeared. Now, this was unimaginable 10 years ago. Just amazing.
Yeah. And, what will the next 50 years hold, of course, is another...
Well, you wonder, don't you? I mean, look at what's happening in our lifetime.
Fascinating question.
We have telephones. Yeah.
No, yeah. Robert, thank you very much. Thank you for your lifetime of dedication to this as well. This has just flowed from that. This has been a very easy interview to conduct, actually, because it just you've lived through it, and there's no substitute for that. So thank you.
Great pleasure, John.
Bye. Come back for the next episode.